Fantastic. Hello, everyone. Thanks for joining us this evening. We know, well, it's several weeks since there's lockdown. There's lots of webinars going on, and it's the evening as well. So what we want to do, we want to keep this sort of to the point and punchy for you guys, so it's not too long-winded or anything. My name's Zaim. I'm one of the dentists at on the team at Kiroku. Obviously, some of you are users. Some of you may not have seen us before or used us before. Kiroku is a web app which helps you speed up your note-taking process and make it really thorough and effective for you to use in clinics. And a lot of people have asked us over the period of time that they've been using us is that they want some guidance to have really good, comprehensive notes. So Reena and I have been working together on creating a nice Perio workflow for you guys. I've worked with Reena in the past for a few cases, had really good results. And what I'll do is I'll hand over to her, let her introduce herself. Throughout the webinar, we'll be using the chat to take questions. So Reena will be keeping an eye on that as well. After Reena's talk, I'll show you the Kiroku workflow that we've put together and how you can implement it in practice. And you'll get an email with a questionnaire. And if you fill that out, we'll give you a CPD certificate as well. So over to you, Reena.
Brilliant. Thank you so much, Sam. I'm really excited to be here. You guys are probably all webinared out by now. So as we said, we're going to keep it short and sweet. I'm going to try and keep it as interactive as possible. I know it's quite a big group, so we've got nearly 200 people in the room. So if we can use the chat, we'll try and get through this in the most kind of engaging way as possible. So today we're going to be talking about, so I'm Reena, by the way, specialist periodontist based in London. And today we're going to be talking about perio in practice. And we've teamed up with Kiroku, which Simon will talk about a little bit more later. And the whole point is right now, dento-legal risks in perio is absolutely huge. And it's something we should definitely talk about. It's worth your total of 1 hour for sure. So let's spend a little bit of time on this. So what we're going to go through are two aspects. So we're going to go through common causes of litigation, especially within perio. And then I don't want to make this hour too depressing. So obviously I'm going to be sharing with you the majority of the time practical ways of actually trying to reduce dento-legal risk. So is it really a big problem? Is perio really something we need to be worried about? Are we going to be going back after COVID and are our patients got enough worries to think about, but are we going to have to now deal with patients like this saying things like, I'm going to sue you, I'll see you in court. So firstly, it is a problem. Perio for sure is the biggest problem medically. These are the stats from Dental Protection, and 3/4 of claims are perio related. So if we have a look at the pie chart, 3/4 are perio and implant related. That is huge. That's absolutely huge compared to any other specialty. You can have ortho, oral surgery, you know, difficult procedures, but yet perio is at the top of the list when it comes to litigation. So number one, it is a real risk, and it is worth us having to look at it and look at how we can reduce the risk. So why is perio such a big problem? So sorry, I think you can see, I'm going to just, someone said you can only see half the slide. Let me just swap my display. Is that better, Hayden? Yeah, okay, perfect. Great. So why is perio such a big problem? Let me ask you guys, okay? So what is it about perio that differentiates it from all the other specialties? Why is it such an annoying specialty when it comes to litigation? What do you guys think? Any offers before I pick on people? Very good, Samira. It's a slow process, absolutely. It's a long process, it's over time. Undiagnosed is the biggest thing, Hayda, correct? It's dependent on patient compliance, chronic condition. You guys are on fire, considering it's 7 p.m. Brilliant. Ongoing disease, poor patient compliance. Okay, all of them are absolutely correct. And it's poorly managed. So let's look at this in a little bit more detail. So why is it such a big problem? Well, firstly, is, as you said, cases cover over extended periods. So perio is classically chronic condition. I know we don't call it chronic anymore in the new classification, but it's like diabetes. It's not something like you get caries and it needs restoring. It's not like you got a broken down tooth and it needs extracting. You've got perio and you're going to have it for life, right? Because once a perio patient is a perio patient, they're a perio patient for the rest of their life. So these cases, they extend from, you know, as short as a couple of years, but can extend up to 30, 40 years. It's really interesting. When I was preparing this presentation, I haven't done this presentation before, I was putting some material together and I was just looking at some of the cases and I was thinking, oh my God, so this case started when you were like, that person was like 10 years old. And now they're making the claim like 40 years later. And they can, because they have perio. So it's worrying because of that. It usually involves more than one clinician, and this is part of the problem when you're working in a practice where some people aren't on it like other people. So for example, if they saw one of your hygienists and then suddenly or a new hygienist came along and they saw the patient and they were an excellent hygienist, as we all should be, clinicians, and they picked up perio, but no one else in the practice has picked it up. As soon as that claim starts, it's not just one person that is looked at, the whole team, and not only the whole team, any clinician that has seen that patient will be investigated. So it's worrying from that perspective as well. Furthermore, people around us don't really help us. They in fact make things a lot worse for us. So law firms, I'm sure you've heard of this, they actually place advertorials in local papers and say things like this, which is, I think, is horrendous. So look at this, right? It's in the Mail Online. This happens all the time, by the way. It's just as one of the ones that I found in 2016. So woman, 28, wins 35K after dentist fails to spot gum disease, meaning she would have lost half her teeth. So this 28-year-old basically went to see 2 dentists who hadn't told her about the gum disease. And then the third dentist, this is always the case, it's a common thing, they go to someone else, someone new, and they said, hold on, you've got a problem here. And then she was awarded £35,000, right, despite the dentist not accepting liability. And then she put in the paper, right, oh, you know, thanks so much to Dental Law Partnership, they've managed to you know, help me with this issue. And then what that does, obviously, is on Mail Online, the readership is huge. That's then going to provoke other patients to think, hold on a minute, do I have gum disease? My gums are bleeding. Why didn't my dentist like refer me, or why didn't my dentist treat this? So that provokes more and more patients to complain about it. So, you know, the environment around us is not helping us, unfortunately, either. It's also a big problem because patients are getting more and more aware of what they require for their oral health. People are looking online, they're researching. I mean, I get patients all the time saying, well, Dr. Google said I need this. And I'm like, you know, we all had that. It's slightly annoying. It's not always true what's online, but people are more educated. So year on year, this pie chart that we saw at the beginning is actually getting worse and worse. So it's really worrying. In fact, the reason why our indemnity has gone up is because of perio claims. It's the biggest problem, and therefore every time our indemnity goes up, it's largely because of perio claims. The other problem with perio, which someone mentioned as well, is future treatment costs, right? So if you think about it, right, perio usually affects the whole mouth, right? It's very unusual to have like one tooth which has got an issue. So if someone is undiagnosed and untreated, and then they lose even a couple of teeth, one implant, right? Can anyone guess how much is a normal implant, would you say, average, for just one tooth, including the restoration? What would you guys say? Yeah, spot on. So like between 2 and 3K is average. Usually, you know, about 2.5K. So if they lose one tooth, that's 2K worth of treatment. Now, if you imagine, I mean, most of the patients I see, generalized perio, they're likely to lose all their teeth if they're not treated. So some of these cases, they end up losing, you know, like 10, 15, 20 teeth. And how many implants are you going to need then, right? How much is that going to cost? So it slowly starts to add up. That cost of neglect and cost of future treatment is huge. So if you're interested, these numbers are so scary, right? Most claims vary between 25 to 75. But there are a few that I've found that were over £100,000. And this is how you get these figures, is because of all this implant work and everything else adding up, the cost of not treating it and the future cost of treatment. So it's really quite worrying when we look at kind of the figures, and when you compare it, if you're thinking, okay, that's a lot of money, I get that, but what about, how does that compare to a normal dental claim? So I researched how much an average non-perio claim is, and it's about 22k compared to the average perio claim, which is 45k, right? These numbers are huge. I mean, like, you know, it's scary, and this is why perio is such a big problem. And this is why our indemnity is going up. So let's have a look at a few cases. Right. So this is just from the GDC website. If you want to get more depressed, you can browse the GDC website. I wouldn't recommend it, but I just wanted to share with you as a lot on perio. So for example, this one here, 2 dentists leave local lady with gum disease and conducted botched cosmetic surgery, which led to loss of 19 teeth. And you're probably thinking, oh my God, how do they even think about doing aesthetic dentistry without addressing the gums? But it is not as uncommon as you might think. It's actually to forget about the gums. It's not glamorous. It's not sexy. I want to do all the aesthetic work. It's quite easy just to push the gums to the side, especially if they don't look bad. But this is what you can end up with. And then, I mean, there are loads. There's loads on the site. I've just picked out one page. 28-year-old local lady with gum disease and future avoidable loss of 13 teeth. And a 28-year-old. It's actually quite heartbreaking. I get really emotional. Like, I'm quite a sensitive person, and sometimes it's not a good thing. Like a couple of my patients over the last few months, young ones especially, when they come in and they say to me, well, Reena, why didn't I see you earlier? Why wasn't I referred earlier? I'm really protective over my referrers. I will never get them into trouble. I will do everything I can to make sure they're in the right, you know, put in the right light. But sometimes you think, you know, and it's usually what happens is they see the referrer and they used to see another dentist and they've changed to the good dentist now. But when I have to say things to them like, I'm really sorry, you're going to have to lose 2-3 teeth, and they're like 28 years old, it is seriously heartbreaking because it was all preventable. We could have stopped this and we could have saved their teeth. Now they're going to have to go through the rest of their life with lots of teeth lost. It's literally heartbreaking. So these things happen. We don't want to be in this place, right? So let's have a look at some 2 detailed cases before this gets too depressing and we move on to how we can minimize this. I just want to kind of set the scene really, because it is important. So there was a claimant, right? This is a particular case. This is what I was talking about, right? Age 10. They were seeing at this practice. So they'll investigate the whole history. So it's huge. So they were seen from the age of 10, and they was under the defendant's care, that particular dentist, between 1982 and 2011. I mean, some of us weren't even born in 1982, right? So this is a kind of recent investigation. The care that was provided, the usual routine exams, scale and polish, restorations, crowns for the anterior teeth, interesting, right? Aesthetic work. Teeth were extracted over a period of time and they were added to a cobalt chrome denture. The claimant then attended a new dentist, okay, usual story, but in the same practice, okay, so even more kind of, you know, shouldn't have happened, in September 2011, and said, I've got some loose teeth. The lower left 1 and 2 were grade 3 mobile, okay, grade 3, so extraction was recommended. And it was at that point that the claimant was diagnosed with periodontal disease. At that point, the anterior teeth, when they were grade 3 mobile, right? It's not acceptable to leave it that long. So the allegations here, and this is the GDC case, was negligence, and it was alleged, and then they come up with various things that you didn't do, right? So failure to make a proper diagnosis of periodontal disease, even though the defendant seemed to be aware that the patient had periodontal disease, because he must have put it in the notes somewhere, bone loss or whatever, he didn't actually tell the patient. And this is a key thing we'll come to, but sometimes it's very, especially when you're having a busy day, back to back, you know, got short appointments, we might just quickly write it in the notes, but actually verbally having that conversation and explaining it to our patients is super important. This particular dentist, although he did a BPE, he didn't do a pocket chart, which clearly this patient has BPEs of 4s, right? You need to do a proper pocket chart and collect the relevant data, including appropriate radiographs as well. He obviously didn't treat the condition. Extraction isn't treatment when you can try and save the teeth. Obviously, the new dentist couldn't have done much more because it was left to a point where they couldn't do anything. And the court settlement here was 43K, right? Kind of the average, huge amount of money. And at the time, unfortunately, the claimant only had 3 remaining teeth. That makes me really sad. Like, you know, we could have done something about this patient. We could have done something to save the majority of the teeth. So that's kind of a common detailed case that will come through medico-legally. The other one, and the other ones that can get more serious are things like this. So this is kind of the other end of the spectrum. And this patient actually got an abscess, an intracranial abscess, not an ordinary abscess. And apparently it was secondary to an oral abscess caused by periodontal disease. So, I mean, this is worrying, right? This is life-threatening. And as we know, the mouth is linked to the rest of the body. So you're not just, if you neglect the gums, you're not just neglecting the gums, you'll neglect the rest of the body as well. The dentist had been treating her over 20 years. And most of these patients, they've been seeing the dentist regularly. And that's why they get angry, is because they've done everything they can. So this particular dentist, they did diagnose periodontal disease, but again, there was no communication of the actual findings and nothing written in the notes. They'd attended 9 times between 2006, 2010, and no advice given about the periodontitis. And can I just say, they might have actually given advice, right? Like sometimes we give advice, but we don't write it in the notes. It's that note taking which is critical. So, you know, this is what what has been written down, but in real life, right, that dentist might have actually given advice, just they have to say that no advice was given because it was not in the notes. And then the judge said there was poor record keeping, a lack of information given about the periodontal condition. And the patient said that they weren't aware of the perio, and they also weren't aware of various risk factors like smoking. If they knew smoking had a role in perio, they said they would have quit. So, you know, again, it's unlikely this dentist wouldn't have given smoking cessation advice, right? We all do it, but they didn't put it in their notes. So it's more than the diagnosis, which we'll come to in a minute. It's the risk factors, it's the recommended treatment, it's the consequences of not treating. There's a lot more to it that we all have to make sure we implement. So if we bring this all together, I'm not going to show you any more cases, otherwise it will get too negative. So if we bring this all together, we start seeing various themes, right? And does anyone know actually that the 2 biggest causes of litigation in perio? I've given you one because it's on the screen. So the first one is failure to diagnose. Does anyone know the second one? Yeah. Failure to refer, Samira, very good. So it's failure to refer. Treatment is kind of, but it's actually failure to refer. Is there anything more you want to say about that? Because there's a bit more to that sentence that's critical. Because you can refer at any time, right? In the notes as well, but it's something else. Appropriate time, perfect. Okay, so it's failure to refer at an appropriate time is your second biggest essentially reason to get litigated against. It's good to know the themes so you can do everything you can to minimize this. So they're the 2 key ones. Other ones include failure to explain risk factors, failure to explain consequences of untreated periodontal disease, failure to provide adequate treatment, and there's many others as well. So, you know, there's quite a lot of reasons why people get litigated against. So let's do everything we can now to switch up and do everything we can to minimize our risk, because there's so many things you can do. It's actually really easy to cover yourself by implementing a few simple things. So let's spend the rest of the time going through this because it's more positive and valuable. There was something in the chat about, Hader, I think you mentioned dentist-patient communication. And then patients saying, oh, the dentist didn't tell me that. That is a common problem, but I think it can happen. But on the majority of occasions, if you put it in your notes and you've actually explained it to the patient on a few occasions, they're unlikely to make that judgment, essentially. So you just have to kind of do your best. Sometimes you can even get, if it's one of those patients and you think they're going to cause a problem, you can actually sign things and consent forms and so on. So, but the more you communicate with them, the better, essentially. So if we look at a couple of things that we can do to minimize our risk, let's just go through the patient journey. Okay, let's go through from the top. in the patient journey, what can we do to minimize our risks? So first is appropriate assessment, right? So whilst we're doing our assessment, what can we do? The second is accurate diagnosis. So have we written down the diagnosis? Have we written down severity? All of those kind of things. Have we included the new classification? You're probably not going to get sued for not using it, but it's probably worth us going over that, because it's been like a year and a bit since it's came out, so we need to try and implement it as well. What else can we do? Thorough explanations are key. I think with Perio, communication is critical. So I'll be sharing with you a few phrases and things you can use with your patients. Providing the treatment required, and then referring at the right time, and then record keeping, as you've all said, is absolutely critical. Without that, it's very, very difficult to defend yourself. And it is a bit depressing talking about defensive dentistry and all those kind of things, but I think it's real life. We have to do everything we can to do the right thing, but also protect ourselves as well. So let's just go through the journey with those points, and we'll pick up a few things that you can start doing, which you may already be doing, but we can just emphasize the things we should be doing along the way. So we said the first thing was history taking. So in history taking, can anyone tell me this is a difficult question, but you guys seem like you're on fire, so let's ask away. Can anyone tell me when you're doing a history for a perio patient, do they normally say to you, oh my god, this tooth is really loose, or do they usually come in with a presenting complaint? What's your experience? Because from my yes, sometimes, exactly, usually, sometimes they don't really say anything, as you guys are saying. And this is what I found when I first started working as a periodontist. I used to and even when I was doing my VT as a dentist and so on, most of my perio patients used to say that they have no issues. And then what happened is I put the chair back, I did a pocket chart, I found like grade 2 mobile teeth everywhere, 9mm pockets, like severely inflamed gingivae, and put the chair up. I'm like, Mr. Smith, are you sure you're not getting any problems? Are you sure, you're not experiencing any looseness of the teeth or any, discomfort when biting? And that, oh, yeah. I guess that tooth's a bit loose, doc. And I'm like, okay, so it is a problem. And then they'll say things like, I said, are you sure your gums aren't bleeding? Oh, yeah, they're bleeding, but isn't that normal? It's just because I'm over brushing, right? And you're like, no, it's not because you're over brushing. So what tends to happen is they sometimes tell you the presenting complaint at the end of your examination, when you only have like 2 minutes left to explain to them what they've got, the value of the treatment, and getting them to motivate them to actually accept the treatment plan. So one thing I'm going to say is, when you're assessing patients, you have to actually provoke the answers from perio patients, because it's much better to get it from the beginning. Then you can talk about it and have lots of time at the end. So actually ask them these 4 questions, right? Really quick. Number 1, do your gums bleed when you're brushing? You have to say when you're brushing, because when sometimes I used to say, are your gums bleeding? They're like, no, they only bleed when I brush. So they're bleeding. Yes, they're bleeding. So you got to say, do your gums bleed when brushing? Number 1. Number 2, are any of your teeth loose? Are you finding any difficulty eating? Looseness is a really strong marker of periodontitis, so it's always worth asking that. Number 3, do you have any bad taste? I usually say bad taste or bad breath rather than just bad breath, because I find people get embarrassed about bad breath and they don't want to admit to it. So I usually say, do you suffer from any bad taste from anywhere? And then the final thing is gum swellings. So I would update your templates, update your history taking to ask those 4 questions from the beginning. That way you're not asking or discussing your history presenting complaint at the end of your examination. So provoke those answers from your perio patients. So that's the first thing. So bleeding, mobility, bad taste, and swelling. Great. The next thing is all about risk factors. So risk factors will come into play when you're doing your history, medical history, social history, family history, diet history. That's all the things you do after you're complaining of. So what are some of the things to look out for perio? So if I asked you guys, what's the biggest risk factor? Let's start from the medical history. The biggest risk factor for perio, what would you say is the biggest one in medical history? Okay, so diabetes for sure, right? And then smoking is in social history. Is there anything else in social history that might come to mind? Stress, great. Sana, that's really good. So most people don't get that straight away. So stress, and then diet, great. You guys should do the presentation. You guys are good. Okay, so diabetes, right? Quick one. With diabetes, is all about control. What is their HbA1c? You need to find that out for a perio patient, especially severe perio. Find out their HbA1c. We need to let the patient know it is a risk factor if it's not well controlled. It will impact on the outcome of treatment. It will impact on your maintenance regime as well. So diabetes is critical to find out, obviously find out what type they are as well. Immunodeficiency, HIV, AIDS, they can affect things like necrotizing periodontal diseases. So ask about that. Pregnancy is a risk factor in the medical history, hormonal changes. I say to the patient, the gums are going to get more sensitive. So before, you could have got away with not using your interdental brush, but now, if you don't do that, your gums are going to bleed. They need to know that. Medications, look out for things like amlodipine, cyclosporin, phenytoin. They're all going to cause drug-influenced gingival enlargement. By the way, that's the new term now. It's called enlargement rather than in the new classification, it's called drug-influenced gingival enlargement rather than hyperplasia or overgrowth, all those kind of things. But anyway, ask about the medications. Smoking is absolutely critical. You need to put that in your notes, and vaping equally as important. We don't actually know how it affects the periodontal health, but what we do know, it helps smokers quit, but it is likely to have some effect. We just don't know what. So vaping cessation, the risks of vaping need to be included in your records as well. So that's a key thing as well. Wow, you guys are still going. Vitamin C deficiency, great. So diet, I'm going to come to you in a minute, Selena. But stress, as you guys said, huge risk factor for perio. And you're probably thinking, how am I going to ask my patient they're stressed? Are you just going to come out with, hey, are you stressed? It's a bit of a weird question. But the way I ask is I'll say to them, because obviously I ask them occupation, and then the next question after that, I'll just say, oh, just a quick question. What are your stress levels like? Because it can impact on your oral health. Would you say it's low, medium, high? I know it's very difficult to measure, but how would you rate your stress levels? And the people who are stressed would definitely be like, oh my God, I'm really stressed. And then that is definitely a risk factor to include. And nutrition. So someone said vitamin C, I think. Who was that? Someone said diet at least. I think someone said vitamin C. So vitamin C, but also things like vitamin D, magnesium, zinc. There's various amino acids. It's quite a lot of ingredients, but you can't recommend a certain thing. You just say you need to have a good amount of nutrition. That's enough for now. Good amount of fruit and veg, and you're fine. So these are all the risk factors. So have a look at your templates. Have a look at how you can implement these risk factors for your patients. Because not assessing the risk factors, missing a risk factor. Remember that case where the patient who was a smoker, she wasn't told that smoking was a risk factor? That was a big part of the claim. So try and make sure you get these covered. Okay, moving on to the actual assessment. So here it's all about probing. And obviously your gold standard, every single assessment checkup thing to go to is your BPE. You must do the BPE. And so this, one of my friends, I don't think that they were joking, but I was just saying, I run a course for hygienists, and one of the problems that they have is sometimes the scores of the hygienists are different to that of the dentists. And so I was telling my friend, I was like, that I remember when we were sitting outside for dinner, those days seem like years ago, but we were just chatting, and I was saying, one of my hygienists on the course has mentioned that dentist BP seems to be different from the hygienist who doesn't know what to do. And then my friend actually said to me, well, sometimes I just don't bother doing the BP. It's going to be the same, right? Just copy out the one before. And I was like, what? And she's like laughing about it. I was like, what? You can't do that. And then that basically spoiled the meal. But anyway, I was a bit offended. But honestly, apparently that's what people do. But you're laughing about it now. If you say that in court, it's not going to be very funny, right? So the judge is going to be laughing at you. So don't just copy out the BP, guys. It's not. It takes like 20 seconds. I think it takes. I timed it the other day. I think it takes like 30 seconds or something. No more than a minute to do a BP. Just don't get lazy with it. I promise you, you will not regret doing the BP. So just do it every single time. Do it across the whole mouth. Don't spot probe. Do it across the whole mouth, buccal, lingual, everything. I had another dentist who said to me, that they only do buccal probing. But you can't do that. You have to probe everywhere, right? So do not get lazy with the BP. If you need to, always take a pocket chart. Remember the other case that we just saw, where they did the BP, but they hadn't done the pocket chart. If it's necessary, you've got a BP of 3 or 4, you need to do further investigations. You need to do a full pocket chart. And as a kind of important point here, don't ignore implants. Implants, treat them like, like you would with a perio patient. They need assessing in terms of oral hygiene. They need assessing in terms of soft tissues. They need assessing in terms of probing. You must always, always, always probe implants. You can use anything you like. You do not have to use a plastic probe. In fact, don't use plastic. It doesn't work as well anyway, but use whatever you have on your tray. Make it easy for yourself. Have your probe ready so that it's just there, your probe's there, and you just use it. It's part of your quick assessment that you do. And remember, for implants, you need to do a 6-point pocket chart, not a BP. So a 4-point pocket chart, 6-point pocket chart, record it in your notes, either on the actual pocket chart, or like if you're on SOE, there'll be that little notes section. You can put it there, somewhere where it's easy for you to access it, because what you'll be looking at is the increase in probing depth. It doesn't matter whether we start off with a 6 or a 5. If it's increasing, that's a problem, and that's when it needs to be flagged up. So it's within your scope to assess it. You don't have to treat it if it's not within your scope. You can if you place implants and you've got the practice with that. But the only thing that you have to do is diagnose it and let the patient know that there's a problem there. You don't even technically need to write peri-implantitis or peri-mucositis. You can just write peri-implant disease, but you've covered yourself. So that's really, really important. I'm just looking at the questions. I say Colette. So Zishan, I have no idea. Like, I didn't see there was any reasoning. I think they said that they thought the pockets, if they were on the buccal, they'd be on the lingual, but obviously that's not true. So Colette, when is best? The thing is, right, just to say, it's very easy to slip into bad habits and think they are normal. Because the thing, no one's really assessed our work since we finished VT and DF dental foundation training. Then we're on our own and we just do our own thing. And sometimes it's so easy to slip into habits that we don't even know are bad habits. So staying up to date is really important. So Colette, when is the best time to do a 6-point pocket chart, in a checkup or when you bring the patient back? Doesn't matter too much. Most people will do it when they get the patient back, so you have more time. But as long as it's done, doesn't matter when. And then, are you sure what should the HbA1c be for diabetics? Does anyone know? Let's see. Anyone in the room know what the level of HbA1c be for diabetics? Perfect. Nia, great. Hey Nia, how you doing? So 48. So 48, does anyone know the units for that? Perfect. So millimoles per mole. Well done, Anika. That is the right unit. The person who says 7 or 6.5, that's also correct. That's a percentage. But they've changed the units recently, so the GPs are all using millimole per mole. So try and get that. So right, we've done history taking. We've done risk factors. We've done assessment. Now we're still on assessment. We're looking at radiographs. So radiographs, you saw again in the cases, were quite a key recurrent theme. Appropriate radiographs not taken. So there are lots of different options, and there's lots of different frequencies in terms of taking radiographs. My key thing would be for you guys to ask yourself, can I see the bone? Right? I'm like a really lenient periodontist. Some people are like, take full mouth PAs. Some of you, literally don't have time to do that in practice. That kind of case probably needs to be referred. But the key thing to ask yourself is, can I see the bone everywhere, right? Can I see the crestal bone? If I can't see the crestal bone with my bite wing, I need a PA. That's it, simple as literally. So if you can't see the bone on the upper 7, distal, take a PA, because you just don't know where that bone ends, and that could change the prognosis. In terms of how often you should be taking radiographs, ask yourself, how will this change what I do? If I take this new PA, and everything else is the same, is it really going to change? Am I still going to do non-surgical? Am I still going to just do a pocket chart? If it's not going to change what you do, you don't need another PA. If it's going to change what you do, or the tooth becomes symptomatic, or the pocket's drastically deteriorated, then you would need another PA. So ask yourself those two questions. So for example, this was a case, actually, medical legal case. This was in 2010. This was in 2015. So you can see that, I mean, here we would need a PA of that lower right 7 for sure. Probably get away with it for the upper 6. For the 7, I'd want to see where the bone ends. This patient then went to a new dentist, and this is how they looked, and this is when they were diagnosed. But unfortunately, there's a problem at 2015. That dentist should have picked that up at that point. And so then this is where the story starts. So any radiographs like this, right, the first one, you need another PA of the uppers. Even this one here, it's not as apparent, but that upper 7, I don't know where the bone ends distally. I need to see all the bone. So just be a little bit careful on your radiographs. So a couple of questions now. So Sana, just to say 6-point pocket charts, how often should they be done? So if you've got patient on maintenance, annually is fine once they're on maintenance, but otherwise you need to do a pocket chart once you've done treatment. So 8 to 12 weeks later, I usually do 8 weeks, take a pocket chart. If they need more treatment, do the treatment. 8 weeks later, do a pocket chart. Radiographs, so Karishma, what if patients refuse, what if patients refuse radiographs even after you've explained why they're important? Is there a particular scenario you're thinking of? Usually I don't have a problem with radiographs, but you just need to, if they do refuse for whatever reason, explain why you're doing them and how you can't really get a diagnosis without them. You'd have to give them a provisional diagnosis. And if you don't have a diagnosis, you can't do any treatment. So I think most patients would be, you need to just reassure them that the amount of radiation is very, very minimal. I think that's usually their worry. What's your opinion on full OPT versus PAs? I love DPTs. Panoramics are great. You can get a great assessment of the whole mouth. The only thing I would say, it depends on the quality of it. Usually though, if there's anything going on anteriorly, you'd want to supplement that with PAs. I have no problems with DPTs. I think they're great. And they save you a lot of time as well. Okay, so assessment, also we're now looking at special investigations. So things like end of frost, EPT, you want to be doing these special investigations, these sensibility testers for things like grade 3 mobile teeth, grade 3 furcation involvements, symptomatic teeth. What I'm talking about here is you're picking up those perio-endo lesions before the patient comes back with a huge abscess. By the way, they're now called endo-perio. Did you know that? In the new classification, they've changed all these things. It's really annoying. So it's now called endo-perio. Doesn't mean the endo is more important, but they just switched it around for some reason, which like still confuses me. But anyway, it's called endo-perio. So you're looking out for these cases before they cause a problem. So with the diagnosis, obviously an accurate diagnosis is super important. So I just want to spend 5 minutes on the new classification whilst we're all here. So a couple of things with this. This was the original one that was released by the European Federation of Perio. This was then simplified by the BSP, this section here, and that was released in the BDJ. You know, if you can't get hold of this, let me know, but this should be online. And this is the actual classification that we should be following. So there's actually kind of 2 versions. There's one of the original one that was released, and then there's one which gives you the kind of implementation in UK practice. So have a read of that. But just to briefly go over this so we're all up to date, there's essentially 3 subsections. You've got periodontal health and gingival diseases, you've got periodontitis, and then you've got other conditions affecting the periodontium. And I mean, the only thing you really need to know about periodontal health, which is a new category, is that the probing depth should be 3 millimeters or less, and there should be less than 10% bleeding, right? A little bit of bleeding is allowed. Obviously, if that point is bleeding, it's not healthy, but on a patient by patient basis, there's a tolerance of, as long as it's less than 10%, they're healthy. See what I mean? The category which you need to know inside out is this one, periodontitis. And now there's only 3 types of periodontitis. Remember when you were all at university, there was that huge table of all the different types of periodontitis. There's literally only 3 now. They've really simplified it. And the one you need to obviously know inside out is the one that's called just periodontitis. And this is the one which everyone seems to get confused about with the staging, grading, and all those types of things. So let's just briefly go through this. Now, you've probably seen the flowchart by the BSP. I've actually broken it down into 6 steps, which I find it a lot easier to use. The flowchart's fantastic, but again, going through the flowchart also takes time when we're back in practice. So these 6 steps are kind of the quickest way of doing it. So let's just spend a few seconds on each. So the first step, by the way, if you guys want this presentation, I'll send it to you once we're done, so don't worry, I'm going quite fast, so apologies. First step is type of periodontal disease, okay? So is there bone loss, because that's a key factor of periodontal disease, and is it due to perio? right? Not all bone loss is due to perio. You might get bone loss due to crown lengthening or extraction of impacted teeth, all those types of things. So you've got to confirm to yourself, is this a perio patient? Is the bone loss due to periodontitis? So if we look at the patient here on the left, there is clearly bone loss. It is clearly due to perio. So you've got your number one, which is you've given a label of periodontitis, right? Simple, straightforward. The second step is to find out how extensive that bone loss is. Is it localized, just affecting up to 30% of teeth? Is it generalized, affecting more than 30% of teeth? Or is it just affecting the first molars and incisors? So here, our patient on the left, you can see the bone loss is everywhere, right? Simple, it's straightforward, it's going to be a generalized periodontitis case. Then the third step, still looking at the radiographs, okay? You're not going to look at your pocket chart or anything at this point. Your first 4 steps, just radiographs. So step 3 is staging. It's all about how severe the bone loss is. So at this point, you pick the worst tooth, right, which is clearly the upper right 5, and you use that tooth to give it the stage. And what you do is you divide the root up into thirds. So Abdullah, you're asking now how to measure the amount of bone loss. So this is how we do it. So we divide the root up into thirds, and if the bone loss is like a tiny amount, it's stage 1, but the easiest way of seeing this is divide the root up into thirds, coronal, mid, and apical. If the bone loss is extending into the coronal third, you're stage 2, mid third, stage 3, apical third, stage 4. So it's 2, 3, 4. So our patient here, they've got obviously bone loss into the apical third, it's stage 4, right? And then you go to grade. So staging was 1, 2, 3, and 4. Grading is A, B, and C. Staging was all about severity. Grading is all about susceptibility. So, okay, I've got this amount of bone loss, but how quickly has that happened? How susceptible is my patient? If you've got a 20-year-old with 80% bone loss, they are clearly susceptible, right? If you've got an 80-year-old with 20% bone loss, they're not so susceptible. So it varies according to how quickly the bone loss happened. So all you do here is take into account the patient's age. So our patient here, right, say she was 49 years old, and you saw that tooth with that amount of bone loss, you ask yourself 3 questions. First question is the bone loss more than my patient's age? If the bone loss is more than your patient's age, that patient is clearly susceptible. It's more than their age, so they're grade C. Okay, so it's A, B, and C for grade. If they're not, if the bone loss is not more than their age, you ask yourself, is the bone loss less than half the patient's age? If it's that, then they're grade A, and anything in between is grade B. So that's the quickest way of doing it, rather than kind of doing the calculation. So that's 4 steps done, 2 more steps left. What we haven't looked at so far are the radiographs, right? And we don't treat bone loss, we treat pockets, we treat bleeding. So now we actually need to know what we're treating. So we go on to step 5, which is the current disease status. So now we need to know, okay, what are we actually treating? What's the current status? Is my patient stable, in remission, or unstable? And stable is everything's healthy. Remission is you've got some bleeding, more than 10%, and unstable is basically any open pockets. So clearly here, this patient is unstable. And then your final step is risk factors. And this is why risk factors are so important that we've now had to include them in the diagnostic statement. It's actually part of your diagnosis. They've only picked 2 risk factors. Doesn't mean the other ones are important. Doesn't mean we can forget about the other ones. But these actually need to be tagged on to your diagnosis, what you call your diagnostic statement. So diabetes, smoking, and previous smoking. So this is what we'd come up with our patient here that we've gone through. Generalized periodontitis, stage 4, grade C, currently unstable, risk factor smoking. So it's really quite easy when you break it down into those steps. These are the flow charts that you can download from the BSP website. So this is the one we went through, 49-year-old, medically fit and well, previous smoker. This was her pocket chart. You then do some radiographs. Here we did 4 PAs because it was super severe. So we said step 1, periodontitis. Step 2, generalized bone loss. Step 3, pick the worst tooth, upper right 5. It's in the apical third, so that's stage 4. The bone loss is more than the patient's age, so it's grade C. Deep pockets everywhere, unstable, risk factor, smoking. Literally will take you like 20 seconds. So hopefully those that will help. Now, if you want to take into account the other risk factors on your actual final statement, you can then write other risk factors, ... genetics, all those kind of things. So you can write those down as well if you want. I do that actually because I quite like to have it in one place. But even if they're in your notes, that's totally fine. So let's do this one together. So 37-year-old, medically fit and well, never smoker, family history of Periodontal disease. Okay, this is the BPE. We did a 4-pocket chart. These are the radiographs. Okay, so let's do this together. Step 1, is this a periodontitis patient? Yes, good. Step 2, is the bone loss generalized or localized? This is a bit more difficult. It's a bit gray, but have a look at the PAs. Is it generalized or localized? Good, localized. Step 4, sorry, where are we? Yeah, pick the worst tooth on the PAs. Step 3, pick the worst tooth. Which one would you say is the worst? Lower left 6, perfect. Is the bone loss in the coronal, mid, or apical third? Mid, very good. So stage 2, 3, or 4? 3, perfect. The patient is 37. Is the bone loss more than their age? And if it is, which grade is it? A, B, or C? Perfect, C. And looking at the pocket chart, are they currently unstable, stable, or in remission? Perfect, unstable. Any risk factors, any lifestyle risk factors here? Okay, so be careful. No is the answer. There are risk factors, but in your diagnostic statement, you don't need to write anything because they're not a smoker, they're not a diabetic. If you want to write other genetics, all those kind of things, then you can. So yeah, hopefully, sorry about my gifts, I really like them. So keep me entertained. So hopefully those 6 steps breaks it down, basically. So there's a video on my, this is another one, I mean, is an example of a stable periodontitis patient, but there's a video on my Instagram which goes through everything in detail. I'm not going to spend time on it now, but have a look at that. It basically breaks it down. Okay, so sorry, Zaim, I'm running like a few minutes late, so I'll be done in about 7 minutes. I think.
Don't worry, Reena. Don't worry.
Fine, sorry. Okay, so this is, we've obviously done the diagnosis. Once you've done your diagnosis, you're then going to explain things to your patient. Okay, so let me just have a look at questions before we go on to explanations. Yeah, so Haida, it was localized at that case because there was mainly bone loss around the molars. To be honest, you could argue that one either way, but overall that was localized. Is it wrong if we write down other risk factors? So you can't write it in your diagnostic statement, right? But then after your diagnostic statement, you can write a line saying other risk factors, and then you put in the remaining ones, right? So it's not wrong to write it, it's actually good. This is just a minimum requirement, basically. Evidence of angular bone loss. Okay, fine. So let's move on. So explanations is key when you're talking to perio patients, right? So you need to say, what is periodontal disease? Actually explain the process. So what I say to my patients is, if this is your tooth, it's held in place by bone. Around the bone, you have gum. Normally the gum's nice and tight and holds everything together. In gum disease, you basically get bacteria which attach to the teeth and the gums don't like it, so they start bleeding and they can open up as well. So you get these spaces forming between your tooth and the gum. Those spaces are called pockets, and why that's so important is once the space is opened up, the bacteria can go inside the space and hit your bone. And if they hit the bone, they can start dissolving the bone away, and slowly that tooth will start loosening up, and eventually, if not treated, you will lose that tooth. Right? Explain to them what a pocket is. Explain the difference between an open pocket and closed pocket. Open is anything that needs treatment, closed is anything that doesn't need treatment. Use terminology that the patient understands. Explain to them the risks of not treating it. Explain explicitly, you will lose a teeth if it's untreated. It may affect your general health, right? So there's all these things that you need to bring in. People always say to me, I'm struggling with motivating my perio patients. It's all about communication. If you went to see someone and they were like, you're going to lose your leg, or even you're going to lose your toe, right? You knew you had an infection on it, but you didn't think you're going to lose it. If someone told you that, and it might actually start affecting your heart condition, you get pretty seriously, motivated by that. So explain the consequences, explain the prognosis, explain if something's guarded, explain if something's hopeless. If they don't want to have that tooth out that you think needs to come out, they need to know this could affect the prognosis of adjacent teeth. It's a domino effect is what I say. If you're not going to, teeth share bone, and if you're not going to have that one out, Mr. Smith, you may end up having to have 2 out if it's left untreated. So use various things to explain the prognosis. Explain your proposed treatment. What are the benefits? And the key benefit is actually trying to save your teeth, right? You're trying to make the mouth comfortable for the patient. what are the risks? Are there any risks? Obviously, the risks will outweigh the benefits on 99.9% of cases, but with the treatment, you will get some sensitivity. You will get some black triangles open up. You will get some recession. But the other option is to leave this and lose your teeth, right? Explain the importance of risk factor control. All those things you've identified, that's great, but you then need to translate it to the patient. You need to let them know about diabetes, smoking, all these kind of things. Explain to them the importance of compliance. This is a joint effort. I can't do all the work. It's 80% about what you do and 20% about what I do. So let me just have a look at the questions. Explain the treatment. If patient stops us from explaining the treatment. Yeah, I guess you get some patients who are like, I just don't want to know, don't tell me anymore. I mean, you should try and explain it if you can, but if they don't want to know, just write that in the notes, just make sure they're aware of the diagnosis at least. So moving on to treatment, be aware of where your patient is in the perio journey. Are they having active treatment or are they on maintenance? It's different. Active treatment is you're numbing up and doing RST. SPT is you're on supportive periotherapy. You're seeing them every 3 months to maintain what you've achieved. With active treatment, you're making things better, right? You're treating it, you're improving things. With maintenance, you're maintaining it. You're not improving it. If you still got pockets and the patient's had to be put on maintenance for whatever reason, you're slowing down the progression. You know, eventually teeth might be lost if there's still pockets. So there's a difference here, and that's a key thing medically legally as well. If you're referring to the hygienist, make sure you got a prescription. And just because the patient has gone to the hygienist, it doesn't mean it's not the dentist's responsibility to oversee it. We all need to be working together, come up with a practice protocol perhaps. Make sure when you're doing treatment, you treat the periodontitis first before any aesthetic treatment. So in terms of things like, another big thing that I'm seeing right now is patients having Invisalign when they've got active periodontitis. Please do not ever get yourself into that situation, because I mean that's really serious, because now you're moving around teeth when there's active inflammation. They're going to lose teeth whilst you're having ortho. So it's really, really important to get everything under control and refer at the right time. What are the referral guidelines? A BP score of 4 plus an additional risk factor, or stage 4 grade C. We need to start thinking about this. This is on my website. It's just to help you on the NHS, like a protocol of when to claim band 1 and 2, because especially with a new change with band 3 only being risk factor control, with code 3 initially only being risk factor control, this may change things up for you. So have a look at that online, and you can download it as well. Thanks, Hannah, for that. So Zisham, before we move on to when to refer, would it stand up in court setting if the literature was given to the patient and they signed everything? Yeah, I guess it would. You have to do everything you can, and I think you're right. You've got to put it in your notes. You've got to communicate. That communication is actually the key thing. The verbal communication is the key thing, because most patients who have been explained it will not then turn around and say, they didn't tell me, usually. If you really want to cover yourself, you can start doing consent forms as well. We've got to do everything we can to minimize our risks. And with referring, and as I said, it's one of the top reasons, it's usually what happens is the patient, you think they don't care, and then they lose a tooth and they're like, hold on a minute, they switch on you. The nicest patients, we've all had this experience, will just switch on you, say, hold on, why didn't you refer me for that tooth? I would have seen a specialist, now you know what you're going to pay for my implant. So minimize any delay. And the kind of cases you want to look at for referral are, what we used to call aggressive, like severe perio, or even patients you've seen for a little while, like twice for perio, and they haven't really improved. You've still got some pockets. And by a pocket, I mean anything 5 and above. 5, you can probably get away with maintaining. It's not ideal, but 6 and above, we need to get that under control. It's hard enough maintaining periodontal health. It's hard. You can't maintain periodontal disease. Any residual pockets, sometimes vertical defects, all those kind of things, gingival overgrowth, and periimplantitis as well. Like this patient here, severe perio across the mouth, deep pockets everywhere, young patient, she's only 32. Look at her bone loss on the upper incisors. Oh, sorry, Hayden, my website. Oh, is it down? Sorry, I think that I'm migrating to a new site. Should be back up. Check in about 24 hours. Sorry. If not, you can email me. I'll send you the flowchart. This is the radiographs. You can see severe bone loss, and this was a treatment plan, right? So with perio patients, you need to work with the specialist, establish a good relationship with someone that will look after you. And some of these cases, even if they're severe, they can be treated. So try and reassure your patient as well. Sometimes you've got to do surgery. Sometimes you've got to cut away the pocket. It's one way of treating it. Sometimes we try and regenerate the pocket. So we try and use things like Emdogain and BioGuide. You can see here the 2 radiographs. One was 6 months later. I'll be a bit happier with the prognosis of that 6 compared to how it was before. So just be aware of kind of the things we can now do with overgrowth. We'd want to do a bit of surgery to make that a little bit better. My email will come up on the last slide. That's one category. The other category is recession, which is becoming more and more common. Look out for these cases. You don't want to miss them. You know, things like this. This is bad news. The gum here is super thin. It's very difficult to clean. Do not leave this. It's going to get worse. This looks pretty angry. We want to refer this much before it looks like this. The patient's struggling to clean this area because it's so sore. So what we need to do is thicken the gum, make it nice and tough, so that even if they get a bit of plaque there, it's not going to recede. But more importantly, it's comfortable for them to clean that area. That's called a free gingival graft. Super predictable. It takes about 45 minutes. It's the patient's sorted for the rest of their life. Sometimes you need to do a frenectomy as well at the same time. Yeah, it doesn't look glamorous, but hopefully no one's going to like pull your lower lip down and stare at your lower incisor. So it's for cases where in the non-aesthetic zone. These are some other examples. This patient was actually referred. They had Invisalign, and unfortunately they got a lot of recession, so we had to do this post Invisalign. For more aesthetic cases, we do things like this. So coronally advanced flap, where you pull the gum down and put a connective tissue underneath. Sorry if I'm going fast, there is a recording after, so you can look back. I just need to get through it in 1 hour. So with things like this, you can pull the gum down and put a connective tissue graft. So aesthetically, if you're doing a lot of aesthetic cases, look at the teeth, look at the gums. Again, legally, patients are looking for these types of things like, why was my dentist not telling me that they could fix this recession? This was another one of my referrers as well. This is Zeem's case. Zeem, who's you spoke on, we worked on this case together. He did some composites up to the CEJ, and then we did the graft. So this was pretty good, I think.
She was a very happy patient. She was lovely.
Yeah. So, and I mean, you know, you might think, God, I can't do anything about that. And a lot of people, what they would do is put composites all the way up to the gingival margin. But Dr. Jaffrey here is very good. So he said, no, I'm not doing that because it's not good for the gums. It's going to make them more inflamed, and then it's going to get worse again, and you're just going to keep adding composites, not the way to treat it. So we worked together on this. So yeah, if you've got cases like this, I love surgery. This is a more complex case here. And then finally, you know, things like crown lengthening, always refer, I think legally with crown lengthening, you're probably not as bad as the other ones like periodontitis, but just be aware of some of these cases and what you can do. I mean, before I did my specialist training, I didn't even know that this kind of stuff was possible. This is Sahil, I don't know if he's here, one of my good friends, and I think he also uses Kiroku as well. So this is one of the cases we did together. So they're super fun to do as well. So just be aware of what's possible, basically. So just to finish on that, in terms of referring, there's various options. If you need a specialist, and it would be fun to work with some of you guys, I work with some of you guys already, but if this is my email, and I can speak to you more about that if you're interested. I'm based in London, so let me know. When you are referring, by the way, make sure you highlight the severity, make sure you highlight the risk of losing teeth, the risk to general health, all those kind of things, and answering their questions. If it's not going to be accepted on the NHS, like it's this classic Perio case, I work at King's, you know, we don't often accept those cases. So it's not within the guidelines to then refer those cases and waste 3 months when they're going to start losing teeth. And expense, there's ways around it, interest-free finance, all those kind of things. What is the cost of not treating it? To always tell them that. It's a lot more expensive to leave it. So this is going to nicely link to Kiroku in a minute, but record keeping, as you've probably now gathered, is critical. Try and make it easy for yourself, and this is why I agree to work with Zeem to do this, because I think the easiest way is that you've got templates that are tailored to what you need. And this is where I think this is extremely useful, especially for Perio. If it's not in the notes, it didn't happen. And so these phrases, what I've now done with the new system, I've created we've both created a workflow where we've actually automatically introduced these phrases. So you don't even need to, like, we'll show you in a minute, but you don't even need to think about them. So it's really, really clever. So I hope you found that useful. Sorry, I went slightly over time, got carried away, but hopefully you got something out of it. So just to summarize, Perio is important. It's the most common cause of litigation, but there's so much we can do to minimize our risk, and record keeping is a key component. Before I hand over to you guys, I'm doing a Perio email series. If you found today interesting, then you might also find this interesting. It's really easy to sign up to. It's bit.ly/Perio School email, and you get an email series. Also, there's a few courses that I do as well. So if you're interested, just drop me an email. I'm not going to waste any more time on this webinar. And that's my email address, info@rwperio.com. I can send you all the slides. You can ask me any questions you like. If you want me to clarify anything, let me know. On any individual questions, I'll answer via email now, if that's okay. Thank you.
Thank you very much, Reena. You did amazing to get through all that stuff in 1 hour. I'm sure there's lots of questions, but obviously Perio is an entire subject.
We could do it, yeah, we could do a lot more.
So send Reena an email if you've got any questions. I'm going to show you the Kiroku workflows that we've developed together. So I know some of you have been asking about how would you actually have all this discussion and get it into your notes in an effective way, because what you don't want to be doing is having like a real detailed conversation with your patient, your next one's waiting, and then having to type it all up freehand. So I know a lot of you are Kiroku users already, and some of you may not be Kiroku users. I'm not going to demonstrate the whole product. I'll show you the Perio workflows and explain how it works. And like Reena said, if you've got any questions or anything, keep popping them in the chat, because we can always look at them afterwards. And just a reminder as well, the webinar is recorded, so we will send the recording out. So if you've missed something, if you want to refer back to anything, then don't worry about that. You will be able to watch it again. So if I just share my screen, there we go. Fantastic. So some people might be familiar with this. So this is my own Kiroku account. So for my note taking, I use Kiroku for everything. And what it does, it's a way to really speed up the way that you do your clinical records. And usually dentists work with templates like on a Word document or in SOE quick notes, like a huge template that you copy paste into your notes. And when we've been speaking to lots of people like indemnity companies and specialists, if you're leaving lots of stuff that isn't tailored to the patient, and that's the key thing, it needs to be tailored to the patient's individual circumstances. If they're going through your notes and you're missing things or things that are irrelevant, then they won't stand up when they're being scrutinized. So if I scroll down, so all my notes come up like this. So this is my template. This is what a template would look like. And what I'm going to show you now is a workflow that Reena and I have put together. So when you have a patient coming in for an examination and you're doing your checks, I can walk through it. So if I just choose my nurse and say they didn't have any complaints, all the stuff that Reena said that's really important to capture when seeing a Perio patient is here. So if you go up, so if they're a smoker, they're a daily smoker, you can write down how much they smoke and how long they've smoked for really easily. And one of the great things about this is that when you're actually engaging with your patient, your nurse can follow through and put all this information in for you. So it's being done without any effort and you're not having to type this all up after the appointment. Same for vaping. So if they're a daily vapor and they've been vaping for 3 years, and say they've got high stress. Reena mentioned stress as a risk factor for Perio. What you'll notice is that because you've noted that the patient is a smoker, in your discussion section, those phrases that Reena said earlier that are really useful, they've automatically populated in your discussion. Now, of course, you still need to tell the patient these things. So say, for example, if for any reason you didn't, you can always delete them out. Or if you had further conversations about genetics and family history, you can always type things in as you need to on top of it, but it provides you with a really good basis for you to do your actual clinical records as well. So we can carry on. So we'll pick the sort of worst possible scenario where you've got a diabetic patient who's pregnant. They're brushing once a day with a manual brush, fluoride-free toothpaste with no interdental cleaning. So all the bad habits. Your discussion section, which Reena's put together very kindly for us, is outputting all the things that you should be telling your patient and documenting. So you can already see this as a large chunk of text. So if you had to type this out freehand, it'll take you a very long time. So you could use this as a reminder for the conversations you should be having, and it will document automatically for you, so that if someone retrospectively had to look at your notes, you've got a really good sort of basis to defend yourself that you've had these conversations with your patients.
Can I just say something there as well, if you don't mind? The other thing that comes to mind as well with some of these cases, you're probably thinking, well, why can't I just use my own template and include all that chunk of text? But the thing is, a lot of the cases that they look at, like for example, there'll be a patient who's not a smoker, but yet they've included smoking cessation. So then it becomes clear that actually these guys have just used their template and haven't tailored it. So did they even give any advice? So I think the beauty of this is it tailors it, and it only puts it in if it's relevant. So I mean, that's really a really important point.
Yeah, that's one of the key things that people say about templates being like detrimental. You don't want to have information that's not relevant. That's the key thing. So again, say if they've got a BP of 4, we're picking like a really bad patient. In my diagnosis, we've got the staging and grading. So in the 6 steps that Reena's outlined, that's something that I found very useful. So when Reena came to our practice about a couple of years ago, or when just after those came out, it's a really easy way to document it. So you can say they've got generalized periodontitis, stage 3, unstable with the risk factors as well. So that's all there, nice and easily again. And going through approximate plaque scores, generalized calculus, so generalized recession, so from 4 millimeters to 8 millimeters, and if there's any mobility, say they've got a few grade 2 mobile teeth, you can record it. You've got your bite wings done, say they've just got caries, you can add that, the bone loss around there, and you didn't take any PAs. So a lot of that information is stuff that your nurse can follow your conversation with your patients. And the idea is that you want to spend more time talking to your patient and actually having these discussions rather than quickly telling your patients about perio and then spending ages writing lengthy notes. So the key thing is a conversation. So when Reena's talking about litigation cases and sort of the whole communication process where the patients say, I didn't get told this, and you can have consent forms, you can have them signed, but it's a combination of everything, talking to the patients, having your notes, having consent forms, having good x-rays. So you can really focus on all that stuff and not have to worry about having to type all these things out. So from that information, it's populated my diagnosis, it's populated the discussion. So I've advised them to use sort of orange and red TP brushes. It's giving me a guidance of the treatment plan of what I should do for code 4 BPE, and talked about how I've offered the patient a referral. And again, for any reason, if you haven't done any of these things, you can always remove them or add more stuff as well. So there's a nice workflow that we worked on together, which hopefully should make things a lot easier for you in clinics when you're seeing your patients. So if you sign up for Kiroku and you want to implement these into your checkups, you can just add them to your template. You can add, just put in brackets, Reena, Wadia, Perio workflow, and we'll add that into your templates. If you're an existing user and you want us to implement these things in for you, again, just give us a message on the chat on the support like normal. And if you do want to know more about Kiroku, what I'll do after this webinar, you will get an email with a questionnaire for your CPD certificate. I can also follow up with some other demo videos on how the entire platform works as well, so you can get an idea. And if you do want to sign up, this is the website. So it's trykiroku.com. And if you put your email in here, you can then start it with an account. And then if you just give us a message, and then we can add those workflows in for you as well. Fantastic.
Just to let you guys know, just because you guys are on the chat, I'll send you an email after this, everyone who's been on the webinar, with the presentation, with the link. Basically, my website's migrating, so it should be up in a minute, but I'll send you the link for the email series and info on referring as well. So don't worry about all of that. You'll get all the information.
I just, silly quick question I should have showed you. So How this works with R4 SOE. So Kiroku works in the Google Chrome browser alongside whatever clinical software you're using. And once you've finished your notes and you've done all your notes for the Perio stuff and the rest of the things that you've done, at the top right-hand side, if you click this button here that says copy notes, that basically copies the text from these notes. And then in SOE or R4, wherever you would normally type your notes out, you just need to paste them in there by pressing Control V or pasting them. And then that will output as a set of notes. And I can show you what that would look like just now as well. So if you just imagine, obviously I don't have SOE at my laptop at home, but imagine this is the text area where you would normally do your clinical notes. If you just paste it in, it'll copy over a sort of free text with all the information, all the discussion, the lengthy discussion you've had with patients, so that if you have any problems in the future and someone ever opens up your notes, you've got proof that you've had these conversations. And because you didn't have to spend so much of your clinical time writing this stuff, you did actually have these conversations with your patients. Fantastic. So yeah, thanks for the comments on the chat. We know it's been a while. We've been an hour and 10 minutes. There's so much stuff in there, Reena, which was fantastic. Thank you so much for putting it for us. Like I said, if you've got any questions, you can email me, you can sign up to Kiroku, you can email Reena, we can always follow up with you. After this webinar, you'll get a feedback form. When you finish that feedback form, we'll email you out a certificate for your CPD as well. And yeah, anything else from you, Reena?
That's it. Thank you so much for listening. I know there's a lot of webinars on right now, so thank you for staying engaged, and hope it was useful, and keep in touch.
Fantastic. All right, well, have a great evening, guys, and I hope you enjoyed that.